Good morning. For those of you who don't know me, my name is Drenis. I'm one of the PEM attendings in the ER, and most of the interns probably don't know me, so welcome. Don't be nervous. Just like you guys are nervous with pediatric medicine, we're nervous with adult medicine, so it's just fair. So I'm going to be discussing rashes today. I'm going to do it a little different. I'm going to show you guys a picture of a rash with no history. We're going to discuss what we're seeing, and then I'll give you a little history, and then we'll refine what we think is going on. Sounds good? All right. I found this pretty funny. All right, so can we shut the lights in the front? Can you do it here? All right, can you guys see okay? Yeah. All right, so what do you guys think? Vesicles. Is that the only thing? So we got vesicles, we got, which one is umbilicated? 1, 2, 3. Okay. Anything else? Yeah, I mean, it's a picture, you can't really see it that well with the lights, but all right, so what are we thinking? So you have the pediatric ED, so it's likely someone less than 18 comes in with this kind of rash. What do you want to know? With their knowledge, they're up to date. That's what Mom said. Came from England 2 weeks ago. No one else. What associated symptoms? That's sure. You go to fever, subjective at home, no chills, no night sweats. Everything happened today. What did you say? They noticed in the same day. Why, you ask? Okay. What does that mean? Okay. Anyone else have any other ideas? Questions? Sorry? No. Not yet. No. Why do you ask? What differential do you think? Say he had mucosal involvement. What do you think? What is it? Okay, that's good. Coxsackie? Is that what you said? Okay, maybe. All right. So, what? They're itchy. So, Molly, what is your, if you had to give one diagnosis, what would you give? Okay. Maya? Monkeypox? Okay. No, listen, that's completely fine. So, I mean, we went over the history, right? It was a 15-year-old male visiting from England, woke up with this generalized rash, right? Subjective fever at home, no other symptoms. All 4 family members came into the room at once because and the call was they're concerned about monkeypox. So we spoke to the mom, spoke to DOH. DOH, after hours of conversation, did not want to test. And we swabbed But the one thing we did is mom said up to date. We looked online and it appears that in England, the varicella vaccine is not mandatory. So ultimately, this came back as varicella, chickenpox, which we don't really see in the US anymore because the vaccine is mandatory. So one thing for thought, if up to date doesn't mean anything unless you know what up to date stands for. So it's transmitted via droplets and direct cutaneous contact from the vesicles, from the skin lesions. Incubation period ranges between 10 to 21 days. And most common, you get it within 14 to 16 days. The period of infectivity is 48 hours prior to the rash until all the vesicles are crusted over. The one biggest thing is the different stages of healing, which kind of points at chickenpox. Now, they said they saw it all today. Unlikely. Maybe they just didn't realize it, or now he was having in areas that were in his face and that prompted them to come in. New vesicle formation generally stops within 4 days, and most have fully crusted by day 6. And one thing we all know about chickenpox that we describe as dewdrop on a rose petal, and that's really on that one right there. You see that one on the top right? That kind of looks exactly what that describes, the dewdrop on a rose petal. All right. This guy, he's a permanent resident at my house. No. Why? What do you think? Very real, like urticaria. Okay. Fevers, yes. Kind of at the same time. No. How recent? 2 weeks. That's right. And 5. He had a anti-surgery. Not that we know of. Joint pain, correct? Why? You're just wondering? Why do you ask?
We know the answer.
Okay.
Let the residents talk.
All right. Why do you think she asked for joint pain?
He had fever, he said, so fever had pain.
Correct. Anyone? I'm gonna start calling on names. It's only the names I know. Does he have? Did he? No. No. Why? It's a good thought, but no. No lymphadenopathy. No. She's running around wild. He's not running around wild. No. Who has that? No. Why? Okay. No, none of that. All right. So let's discuss. 5 years old, 2 weeks prior had an appendectomy, fever, rash. One ankle was more swollen than the other. He was complaining of pain with walking, itchy, and it started 2 weeks after the administration of medication. He only got 1 dose of ceftriaxone, and he got 2 or 3 doses of flagyl before his surgery. Anyone have a top differential? Who said that? Serum sickness. Good. Anyone? Paul, you look very focused. Good. So he had It's a serum sickness-like reaction. You guys know the difference between serum sickness and a serum sickness-like reaction, or what do you usually get? Serum sickness is usually due to what? Yeah, it's like blood products, animal-derived serums, like anti-rabies serum. So this is more of a serum sickness-like reaction, and it can be seen 1 to 3 weeks after the exposure to the inciting agent. The most common medication is cefaclor. I mean, I don't think I've never given that, but it can be other medications. It can be penicillins, it can be cephalosporins, and the rash can be urticarial, morbilliform, or EM-like. There's joint swelling, fever, arthralgias, and lymphadenopathy. And unlike classic serum sickness, right, we don't see that frank arthritis, the liver or kidney involvement. And I don't know why it's supposed to be CNS. It must have autocorrected. CNS involvement is rarely seen. And then one over here, which you can't really see because of the light. This one has central clearance. So this one is almost EM-like, and the other ones look like more wheels and urticarial. And this is him now with the little one. Yeah, they look so cute in the picture, right? All right. This is a girl I saw in my second year of residency. What do you think? How would you describe these lesions? What? Seems like a little bit. Could be a little bit of fluorosis. Anyone else? The bleachers? Yeah, it's feeling. Yeah. I have another picture as well. No. She is 6. 6. Fever, I think she had a fever, yeah. Fever before. What are you guys thinking? Or how do you describe these? What'd you say? Why? Anyone agree, disagree? Different thoughts? No, she's healthy. No? No comments? So just like we said, she's 6-year-old fever, 6-year-old female, fever, generalized redness of her skin, right? So she has that erythrotherma, pain to touch. On exam, her skin blanches when pressing on it, right? And you notice that her skin is peeling off with rubbing. What sign is that? What sign is it? The Kolsky sign. So do you guys agree or disagree with Jasmine? But you guys did you ask me if there's any oral involvement? Did anyone ask me? Or mucosal involvement? You didn't ask me. Now you read it. So it's staph scalded skin. It's bacterial toxin mediated that primarily affects young children, most commonly less than 6. The characteristic findings is diffuse skin pain and erythema, as well as superficial blistering and desquamation. They usually arise from a focus of infection. Most commonly, it's MSSA. And the initial onset of erythema and skin folds followed by rapid progression to widespread erythema, usually within 48 hours. These patients, I mean, really what derm came and they did they took a skin sample and under the microscope, they diagnosed it with staph scalded skin. And you only really need like nafcillin, oxacillin. You don't need MRSA coverage for this.
So you guys notice the inflammation when the blister pops, there's inflammation.
Mhm.
And that's when
No, yep.
it comes off, it's not there. It's just-
So different child, similar age, and complaints, but this time you notice this. What's different? Anyone? What? Nicole, so what are we thinking? SJS? Right. SJS could be TEN. I mean, we don't know the amount that's involved. What? I don't know what percentage would be SJS. I don't know. What is it? More than 30? More than 30 is TEN. 10 to 30, 10 to 30 is SJS and more than 30 is TEN. You ask a question, you gotta be ready. All right, so Stephen Johnson's. So it's a hypersensitivity disorder affecting skin and at least 2 mucosal surfaces. So that child had eye involvement and mouth involvement. Less than 10%, I think it's 10 to 30 of body surface area. Most common are NSAIDs, penicillin, sulfonamide, antiepileptics. Incubation period is 1 to 21 days. And these are the type of patients you transfer to a burn center. It's amazing how most of these hypersensitivity syndromes that are involved with NSAIDs, but yet we take them and give them out like water. Any questions? All right, let's move on. What do you guys think? Okay, so palpable purpura, and you said HSP? Okay. Anyone else? He's not sick. I mean, you can have just a rash. I mean, I can tell you he's having joint pain. I can tell you he's having plus or minus abdominal pain. We're all on the same page. You think it's HSP? All right, so he was a 7-year-old, presented to the ER, rash mostly on his legs, few days of abdominal pain and joint swelling. Right, so this is HSP. It's most commonly seen in ages 2 to 11. It's the most common cause of non-thrombocytopenic purpura. It's most prominent in the lower extremities, and you can see GI pain, arthralgias, arthritis, and testicular involvement is involved in 35% of patients. What's one thing you want to test on these patients? I mean, if they're in severe pain and they're in that age group, you can do an ultrasound. Is it intussusception or is this like a vasculitis, renal function, right? So you can do a BMP, you can get a UA, and you're checking for what? Protein. And creatinine will help you as well, but even with proteinuria, if it's mild, usually they say if it's less than 1 gram a day, you don't treat. You don't have to give steroids. You don't have to treat these. If it's severe, almost like debilitating, you can't walk, you can trial prednisolone for 5 to 7 days, but it's not the common practice to give it. Now they should follow up, obviously have UA done if there is renal involvement, just to monitor it's not getting progressively worse. Any questions? All right. What are these? Oh, you can't even see it. All right, this one. Crusted lesions, okay. Do they look the same? Do they look different? It just says like present. I don't know. There wasn't this much technology when I was here as a resident. It was very easy. Like, I'm pretty technologically savvy. I don't know what to do with this. All right, so are they the same? Do they look different? They look different? So what are we thinking? Anyone? They're clusters, yeah. Right. So it's a 3-year-old in the first picture you can see, 3-year-old male, newly placed in foster care here with widespread rash, no fever. Right, we see these. We see this rash, very little history. What is the one piece of history you want to be able to elicit on this patient to help you with the diagnosis? Foster mom thinks he has eczema. What do you guys think? So it's eczema herpeticum, right? It's not that uncommon. It's a disseminated cutaneous herpes, and it's usually superimposed on a pre-existing condition like eczema, right? And atopic dermatitis. It's most commonly caused by HSV1. We treat with acyclovir, but do you know what the time span is from the time of onset of lesions to the recommended starting of acyclovir? Is it 1 day, 2 days, 3 days, 4 days, 1 week, 2 weeks? Yeah, 72 to 96 hours is that optimal, that window you have. 72 hours is ideal, but you can go up to 96 hours, especially if it's severe. If it's around the eyes and the face, you want to get opto to see if there's any dendrites within the eye. Yeah. Yeah. It's better safe than sorry. If it's that extensive, yeah. All right. What do you think of this rush? Minus the Band-Aid. Maculopapular? Fair enough. What is it? Morbilliform. Okay, and maculopapular, morbilliform. What do you want to know? Fully vaccinated. Amoxicillin. They just, yep. Treated for strep. Presumed. What does rash feel like? Bumpy. It's 15. So what do you do? What do you think is a diagnosis? What do you tell him? Do you work him up? Do you send him home? No fevers. No. Yeah. All right. Yeah, you just tell him, A, you stop the medication, right? It's most likely not strep if he's having this kind of reaction, right? So it's a morbilliform rash. It's a delayed type immune reaction. It's not an allergic reaction. You don't tell him he's allergic to amoxicillin, right? It's just an immune reaction to the amoxicillin. And it's predominantly involves the trunk and upper extremities. It evolves rapidly, reaching the maximum extent 2 to 4 days after discontinuation, but it can happen 1 to 3 weeks after. Often occurs with resolution, occurs with some desquamation. In dark pigmented skin, you can have post-inflammatory hyperpigmentation. And the most important thing is just to stop the offending drug. All right. Now this little guy. What do you think this is? Dangerous. Let's start with dangerous, not dangerous. Why? What's the first one you said? Okay. What do you guys think? Dangerous or not dangerous other than Shane? Not dangerous? Do you agree with Shane? Do you disagree? You agree? You all agree? Are you sure? 1 year extension in residency if you're wrong. No. I mean, if you're that sure, it's got to be something big. So yeah, you're absolutely right. It's erythema toxicum neonatorum. Good job. Yeah. So it occurs in 31 to 72% of infants. It's immaturity of the pilosebaceous follicles. You get erythematous macules, papules, and that rapidly progress the pustules. It bears upon and soles, and they typically appear within 24 to 48 hours. The most important thing is, especially if you have a new parent, is reassurance that this is benign, it is common, and it will resolve within about a week. This rash, dangerous, not dangerous? Not dangerous. Why? Because it's not. Doctor, why is it not dangerous? Because it's not. What do you guys think it is? All right. What? Yeah, because they're in different stages. So it's neonatal pustular melanosis. It's also one of these benign infant rashes that you guys just need to know and reassure the parents. Small pustules, non-erythematous base, present at birth. They start as macules, they can develop into these pustules, and they can persist for weeks to months. No treatment is necessary, just reassurance. All right, what are these? Dangerous, not dangerous? Not dangerous. Why not, Paul? So maybe dangerous. No, not dangerous. Okay, what if they have 10 of these? What are you concerned for? Who said that? So these are cafe au lait spots, right? They're hyperpigmented macules, 0.3% in white and 18% in African-American newborns. If you see 1, 2, 3, there probably isn't anything to it. However, if you start seeing, I think it's more than 5 or 6, you have to at least have a high suspicion, with the whole picture to make sure it's not neurofibromatosis. Yeah. They should have, they should have a history that someone in their family will have it. But again, if they were adopted, you don't know. No, I don't think it's the fry. It can happen. The criteria is pre-pubertal and then post-pubertal, depending on the amount. I can't remember off the top of my head how many, but it can just happen at any time. All right, and I think this is the last one. What are these? Just like hypopigmented, if you can see them. What'd you say? Ashley spots? Are you sure? Yeah. So dangerous or not dangerous? tuberous thing? Yeah, so I mean, just, these are ashy spots, right? They can be concerning for tuberous sclerosis. Now, if you see these spots and and the child less than 1 is coming in with clusters of seizures, be on the lookout for, this might be infantile spasms. So that's how you correlate this rash with something else. And that's it. You guys have any questions?